I wanted to briefly talk about a few of the items we use to restrain our patients for this radiographic films that we are sending in. But one is the trough, is most common for when the patient is in a VD position. Another one is ties. There are either rope ties or you can make these out of gauze, which are also important as well. But these you can secure to a limb and pull, and that way your hand is out of the primary beam. And then there are also sandbags. We do not use sandbags at this clinic. We do use old water bottle saline bags that we will use as needed to kind of prop heads. We also use towels, and those are just to get limbs as needed, and that way you can step away instead of manually restraining them. So I'm going to be discussing the radiation monitoring device. So this is a thermoluminescent dosimeter, and this registers a charge over time if the person that has been wearing it is exposed to radiation. They do maintain that charge for the duration of the time required by the facility. The radiation protection officer would then replace these at that time, at a specific time, so that they can be read for that specific interval. Each one is registered with the person's information. This one is specifically has my name on it, and they should be worn attached to the thyroid collar, which I'll demonstrate later, outside the apron anytime they are restraining patients or within the area of the x-ray machine. The maximum permissible dose per quarter is 1,250 millirems and 5,000 millirems per year. So these are reported, and then you can print the report to make sure that the dosage is within the maximum permissible dose. So the report is obtained online. We go online and log in and are able to get the report, and we would find one specific member, and for this person I'm going to look at Lauren Gregory. So for this time it talks about it has a key to help us read the report, but it shows the name of the person, where the device is located, whether it's being worn or if it is a controlled device, and then it also gives us different doses. So there is a current dose per year, and then lifetime dose. So even when we're getting these new dosimeters, it's still going to have a lifetime dose reading. So with this, on each line, it gives us, for the current dose for Lauren, it tells us the deep is 22, I is 21, and shallow is 20. So what that means is, and it explains it on our key here, that the deep dose is the whole body exposure. The eye dose is the external exposure to the lens of the eye, and then our shallow dose is the external exposure of the skin. So with those readings for Lauren, 22, 21, and 20, we can see here that the threshold level would be for deep 1250, eye 3750, and then shallow 12,500. So she's nowhere near those. So we know that for this current dose, she is not near that maximum permissible dose. And then we could even see that as current for the lifetime as well. And these can be printed for each of those intervals that we have the dosimeters. And then we always can look at that lifetime as well. Okay, I'm going to demonstrate inspecting PPE for any defects prior to use. The first step would be a visual inspection. We could either lay the apron out, or in this case we do have hooks, and we're just going to visually inspect the entire apron, looking for any tears, perforations, or imperfections such as bumps, and then we would take note of those. The second step would be a tactile inspection, which basically we're going to run our hands all over the apron, looking for any thinning of the lead or creases, and then again we would just kind of note those areas. And for the third part, we would actually lay the apron out on the x-ray table and take an x-ray of the PPE. And there we're looking for breaks in the lead lining, and those usually appear on the x-ray as dark slashes. So the main pieces of PPE are the lead apron. It should be secured, whether it's either Velcro like this one is or tied. We want to make sure that it's not going to slip or fall when moving, especially around the shoulder area. If you're bending over, you don't want it to fall off. The second piece is the thyroid collar. It attaches on top of the apron. secures in the back, and this is actually where your dosimeter is actually attached. So this is attached to the bottom of the collar. We also have lead gloves, which should be used anytime you're restraining a patient with your hands. But it has loops on the bottom side that your fingers go through, like such. And then you have the lead part on the top. And again, this should be worn anytime that you are restraining a patient. Other aspects that you can wear are lead glass goggles that are available for eye protection. And then there's also movable protective barriers, which would be lead barriers that are mobile that you can move as needed for added protection. Okay, so some basic radiation safety measures are that no portion of any human, shielded or unshielded, should ever be exposed to the primary X-ray beam. And the reason for this is the primary beam can actually produce severe and permanent local injury from only momentary exposure to the radiation. Furthermore, there's should be appropriate restraint methods to maximize the distance between the person and that primary X-ray beam. And a lot of this is going to be using restraint devices, which can be sandbags, foam blocks, tape, gauze, bungee cords, and there actually are commercial positioning devices to assist with allowing that person to move as far away as possible from the primary beam. And that also goes along to say that anybody that does not need to be exposed to that primary beam should be removed from the area. So any non-essential personnel that does not need to be there does not need to be exposed to that radiation, so they should be removed from the X-ray suite. And that's also why we make every effort possible to take as few images as possible, and that is to limit that radiation exposure not only to the technician or the assistant, but also to the animal itself. We want to minimize that, so we try to take as few images as possible, hopefully getting it on that first exposure. And lastly, that is why there are such strict restrictions placed on people under the age of 18 and as well as pregnant women for health reasons. We want to prevent exposure to any type of radiation, so there are strict restrictions on whether they can now be exposed even with PPE. They don't even need to be in the room to have any type of exposure to that radiation, like I said, for health reasons, because they definitely need more protection than anybody else. Okay, I'm going to be doing my lateral radiograph of the tibia and fibula. So my patient is in a lateral position. I have her head and front limbs in natural position, extended out of the way. Right now we're using some towels to keep them in place. I will measure at the mid shaft of the tibia and fibula of the affected leg. Once I have my mark, I will then adjust my settings. My beam is actually going to be centered at the mid shaft of the tibia and fibula. My borders are going to be my stifle and my tarsus. The unaffected leg I'm going to extend back out of view and just leave the affected leg in a natural position. I have my marker in place as well. Clear. My lateral tibia and fibula. Okay, I'm going to do my cranial caudal view of the radius and ulna. I have my patient in sternal recumbency. I have her head moved to the side away from the affected limb, and I have my affected limb stretched out. I have measured at the mid shaft of the radius and ulna, and I'm going to be collimating from the elbow all the way to the carpus. And I have my settings in place. I've already measured. So I have my strap that I'm using to actually pull the affected leg forward away from the body. Can you pass me the pedal, please, Sean? Thank you. once I have my limb stretched out and my beam is centered on the middle of the radius and ulna, I'll take my picture. Clear? Stay. And that is the craniocaudal view of the radius and ulna. Okay, I'm now going to do my lateral abdominal radiograph. So I have my patient in right lateral recumbency. I have her front feet and head positioned naturally. The front feet are actually being pulled cranially by Sean. And then as well as her back legs will be pulled caudally just in a natural position. I'm going to measure at the caudal aspect of the 13th rib. And that is where my central beam will go as well. I'm going to set my settings based on those measurements. And then position her correctly. And again, my central beam will go on that caudal aspect of the 13th rib. My borders are going to be the caudal aspect of T7 all the way back to the greater trochanter. So once I have that lined out, I'm going to stretch her back legs caudally, her front legs cranially to get that extended. I have my marker in place as well. Clear? My lateral abdomen. So I'm going to be taking my ventral dorsal view of the thorax. I have my patient in dorsal recumbency. We have him in a trough. I've already measured. I measured over the caudal border of the scapula, so I already have my settings in place. My central ray is going to be at the caudal margin of the scapula, right between the 5th and 6th ribs. My borders right now I have collimated up to the thoracic inlet, all the way down to the first lumbar vertebrae. And I'm actually going to shorten this quite a bit. Okay, I'm actually then going to extend the forelimbs cranially while holding the head as well gently forward. And Sean is just holding the hind limbs in place, stretching them slightly caudally, just making sure that he stays straight. Clear? Oh no, buddy, it's okay. Okay, and there I have my ventral dorsal view of my thorax. Okay, so I wanted to demonstrate proper use of a caliper and getting the measurements. In my videos, it's a little brief, so I want to make sure I demonstrate the proper use. So in the caliper, you have your area depending on the view of the thickest part of the body or where you should measure. And then based on that, where the bottom of this hits, so in this case 14, we'd have our reading. So with our machine, we have a technique chart that has been created specifically for our machine. And so with this technique chart, it gives us a spot based on those centimeters on this caliper. So if we got 14, depending on what area of the body, it gives us our measurements. So we have an area for thorax, abdomen, pelvis, shoulder, skull, back and spine, and extremity. So depending on what reading, so we got 14, and if we're doing x-ray of a thorax, it tells us our KVP, our time, and then our MAS as well. So we have that right here. And that would be what we then enter, turn this around, on the x-ray machine with our KVP and our MAS with our dials. So based on everything, we get off that caliper in what area of the body that we are radiographing. Okay, I'm going to be taking dental radiographs. The views I'm taking right now are going to be the lower premolars. Right now I'm taking 305 and 306. So I have, my sensor is going to be resting against the premolar surface and against the lingual surface of the mouth. at an angle. If I need to, I can use gauze to help keep it in place. And then my tube head is going to be at a 55-degree angle. Excuse me, at a 25-degree angle, aimed directly at the sensor. And then I'm going to step away for 6 feet from the tube head to take my radiograph. Clear. There I have my dental radiograph of 305, 6, and 7. Okay, I'm going to be doing my second dental radiograph for this. I'm going to be doing a molar, so this is going to be 309 and maybe even 310 with it. So with my sensor, it's actually going to be parallel with the tooth. So I'm going to actually put it directly behind 309. And then my tube head as well is going to be parallel to the sensor. I'm going to use some gauze to help keep the sensor in place. And align my tube head parallel to the sensor. And then I'm going to be at least 6 feet away to take it. Clear. And there I have a dental radiograph of 309, 10, and part of 311. So here I have our radiology log, and even though we do utilize a digital system, we still have a radiology log. And with this log, there are some set fields that we fill out for every time any x-ray is taken. It starts with the date, the owner and patient name, their species, weight, and then what views we're taking, also the location of those views, and then our measurements. We have our KVP and our mass as well, and then we list our tech and our doctor that we're assisting in case there are any questions regarding the x-ray in the future. You'll see there is a blank spot here, and that is for x-ray number. So back before we did use digital and we had standard x-rays, each x-ray would be labeled with a number, and we would attach that number in this log book. So anytime we do a radiographic study on a patient, here at this clinic we use both paper charts and computer. So we are both digital and paper chart as a backup. So anytime we do a radiographic study, we enter it into the patient's chart. So in here we would write that we did radiograph how many views and of what, and if we send it off for interpretation of a specialist. And then in our computer system, we actually would enter a line item of radiographs, how many views of what, and we even have a spot to put information on our dosages, so our KVP and our mass. If we get a report from the specialist, say we send it off for the specialist and get a report back, or if they go for an ultrasound or any specialist, we get a copy of the report, such as this, that would go in the paper chart. So we'd have it in with the paper chart. It also gets scanned and attached to the patient's folder. So we use AVMA2. We actually have a line item that we would enter that is, I don't know if I can see it on here, but it says, in this case, a radiograph report. And on that report, after it is scanned in and saved on our server, we'd put in that line item, and in this case, attach the specialist report. So then we have the specialist report attached to the digital chart of the patient. Okay, so today I'm going to be doing my GI series. I will be doing an abbreviated series. Ideally, for the GI series, I would take 4 x-rays prior to the administration of the contrast. I would take a dorsal ventral, both right and left lateral, and a ventral dorsal. And then the administration of the contrast would be given, and we would take the initial view. that I will be doing today, administering a small amount of contrast of barium, and then taking the initial x-ray. Ideally, after that, you would take a view 15 minutes later, 30 minutes later, 60 minutes later, and then every hour until the study is complete. Again, today we'll just be administering a very small amount of contrast and doing the initial x-ray. So I'll be beginning that here in just a few minutes. Okay, I'm going to be administering the contrast for my GI series. I'm going to be using barium sulfate suspension. We're doing a small amount for this abbreviated series, so I'm just going to administer by mouth. See. And then we're going to immediately go over and take our initial view. I've already measured for the right lateral and have everything collimated as I need, so I can immediately take this view on her right lateral. Sorry. Sadie. Stop. You're okay. You're okay. You're okay, baby. Clear? Okay, and ideally, again, I would set a timer and take another one in 15 minutes, and then again 30, 60, and every hour. Okay, I'm doing a radiograph of the ventral dorsal hip for our OFA view. So I have already measured at the thickest part of the hip. My patient is in dorsal recumbency. She is sedated. So I'm gonna, once I have my measurements and I have my machine set, I'm gonna make collimate to the crest of the ilium, to the distal patella. So rotate medially so both of the stifles are parallel with the patellas right in the linear groove. Go down smooth, just sit back. Clear. All right, and I'll make the few adjustments I need until I get the perfect shot. So for my lateral and modified whole body views for my bird, I know ideally the correct way to restrain the birds is with tape. For the lateral view, tape would be placed across the neck. The wings would be superimposed, and we place tape across the dependent wing first, and then superimpose and place tape. And then both of the legs would be extended and taped as well. You do have the option to tape the tail as well. This is ideal so you can step away from the table to take the x-ray. Due to the health and the situation with the current patient we are using, we are going to manually restrain him instead of using tape. So I just want to talk about where the tape would be positioned. It would be gently removed going backwards just as you did forward. So you would remove the legs first, then the wings, the top, and then the bottom, and then the neck last, restraining as you went. Same thing for the modified whole body. The only difference would be the wings are no longer superimposed. They are separated and taped, as well as the rear legs. They are separated and taped. And again, you would remove the tape just as you placed it, going backwards, legs, wings, and then head. But again, due to this specific situation, me and my doctor who will be assisting me will be manually restraining him, and that's just for his safety at this time. I'm very sorry. I know, I'm very sorry. I'm sorry. I'm just trying to grab your feet gently. So I'm going to be doing my lateral view for a bird. We have his head restrained in a natural position. I have his wings pulled dorsally and they are superimposed, and then his legs are pulled caudally and they are superimposed as well. The central ray is collimated to the xiphoid, and since this is a small bird, we're getting as much of the body included as possible, and I have my marker in place. Clear. And my measurements were due on a already created template we have for birds, so there's nothing to measure for him. We use the same template for all small birds.
Perfect.
And then his little feet are kind of... Okay, so for my modified whole body, I have the wings spread out as well as the rear limbs. All my other settings are the same. Good bird, good bird, good bird, good bird. But I had my central ray focused on the xiphoid, and again, both wings were spread dorsally and no longer superimposed, and then pelvic limbs were spread out as well, no longer superimposed. His head was stretched out naturally in a cranial position.